This is geared toward people who might be a little bit newer to the STAR project, just to show you guys what we have done in terms of using research tools to measure some of the impacts of self-testing in the population, as well as introducing you to some of the tools that are available for you to freely use in your future research. So the goals of this presentation are to provide a quick overview of one of the STAR interventions that we're evaluating using an impact evaluation, and this is the community-based distribution of HIV self-tests. And in doing so, I really want to highlight the data capture tools that we've used to measure the outputs, outcomes, and impacts of this evaluation. So I'm going to be talking very much about data collection tools and less about some of the other research methods that we've used, although I'm happy to answer questions about those. So we're all, I think, fairly familiar with the question of the different distribution methods. How should we best distribute HIV self-tests to get them to the people that we think should have them? One of the distribution methods that's being used in all of the STAR countries at this point is a community-based distribution method. So community health workers, community-based distributors we call them, are distributing self-test kits within rural areas in Malawi, Zambia, and Zimbabwe. The examples that I'm going to be talking about today are from Malawi. In doing these impact evaluations, we've used a cluster facility randomized design. So facility catchment areas are randomly allocated in both Malawi and Zambia to receive community-based distribution of HIV self-tests or no distribution of HIV self-tests. And as you'll see, the inputs, so I've unpacked we usually talk about a specific impact that we're interested in, but for those of you from the program evaluation world know that we usually have to unpack that a little bit. We can't just say, this is what's going to happen. We want to know all of the different steps that are taking us from giving a self-test kit to a community-based distributor to actually having one of our important population members or a community member test and know their status and possibly link to future care. So I've disaggregated this into inputs, outputs, outcomes, and impacts. And in order to answer our research question, which is our impact, whether or not more people know their HIV status after introducing self-tests, and whether or not more people with HIV and AIDS are on treatment, we have to know inputs, outputs, and outcomes. So how many self-test kits are being procured, how many are being distributed, how many clients are using these kits, what sort of training materials are being provided, what sort of information is being provided to the community members about self-testing, and whether or not clients are linking to prevention or treatment. And additionally, we tend to think of the positive outcomes, but there are also adverse outcomes that we need to be very aware of, and people are very worried about in terms of HIV self-testing. And this would include adverse outcomes as a result of forced disclosure or forced testing or other things. So in order to get the thing I think that Francis Cowan talked about at the very beginning is very relevant to all of the work about HIV self-tests, which is that we let them go. And I think that researchers are in particular very excited about holding on to things and being able to measure things at every step so we know exactly what's happening. But we can't do that with self-tests. Part of the joy, part of the power of the self-test is the fact that we're able to give someone the power to do the test themselves. So in designing a data collection system for this, we have to balance that. We have to, on the one hand, we want to know what happens at each step of the community distribution process. So what the distributor does, what the client does, and what the facility does. But at the same time, we can't control that because we're giving this self-test to a client and hoping that they will take the initiative themselves. So the strategy that we've used in STAR is to collect data at different steps in the distribution process and from different actors within the distribution process. So I've created some nice graphics, so you can sort of enjoy little pictures of houses and things as I talk about the different, somewhat dry data collection tools we use. So the CBDA, the community-based distributor, will bring the self-test kit, something called a self-completed questionnaire, which is completed by the client, him or herself, and a self-referral form. Again, this is for the client, him or herself. The CBDA will complete a registry entry with information on the number of test kits distributed in that household. And in Malawi, this register is actually paper-based, and it contains quite minimal information, but it will give us a sense of the number of test kits that are being distributed and who receives those test kits. The next thing that has to happen, so that's the community-based distributor taking and collecting some data, and then next we rely on the client to also give us some data. So we have boxes located in a variety of areas where people can drop their self-test kit once it's been used, and the self-completed questionnaire. So the self-completed questionnaire, again, is completed by the client, him or herself. And we've designed it to, the one in Malawi is in Chichewa and English, and it also includes pictograms, and the CBDA will explain what the self-completed questionnaire is for and what it's asking as he or she provides it to the client. So we hope that we're trying our best to get information from clients even in low literacy areas. But these include information on some very general information about who the person is in terms of sex and age, what they thought their result was, and then positives and negatives about the self-testing process. So we're both getting satisfaction with self-testing as well as one of the many ways that we try to get some of the adverse outcomes, whether anything harmful happened, whether or not they were forced to test. The next thing that happens, we hope, is that clients who have a reactive self-test go in with their self-referral form to the facility. And the self-referral form is designed, it has, I think, two purposes actually. On the one hand, it has the data purpose, which is the one that I tend to be most interested in. It helps us understand who is linking and where they're linking to. But it also serves, I think, as something that's helpful for people, that they have a client who might not be familiar with the facility or might not be comfortable with it, has a piece of paper that sort of says, I can go to the facility, this is who I am and what I need. So the self-referral form is the thing, again, so this comes from the client and goes to the facility, so we have both of those actors working. And it includes information on the client as well as things that will tie them into the electronic health records or however health records are being collected. So ART numbers, facility codes, and information about the diagnostics. I should say I focused, so when I wrote this, it was before the beginning of the workshop. I was not procrastinating, which is good, but also bad, because there's been a lot of questions here on linkage that I didn't necessarily capture in my slides. So this is one of the ways that we capture linkage. We also are attempting to capture linkage through routine data collected from the ART facilities. So we're extracting data from clinics to use that data to see whether or not there's linkage. I would caution, I think, and we can talk about this a bit more, one of the things that, I've been hearing a lot of, people don't link, do people link? And I think there's a challenge even before understanding why people don't link. I think that we have a real challenge in understanding whether or not people link. Because we're relying, in the self-referral form, we're relying on both a client and a facility to feed information back to the researcher. And then in the facility records, we're relying on the facility records to have a field available that captures information about HIV self-testing. So one of the challenges, I think, moving forward, particularly to scale, and particularly when, if linkage is such a concern that we really want to measure it, is that this has to be really taken into the programs who are providing ongoing HIV care. It can't just be a research initiative. And then the final thing, and this is the thing that I, as an epidemiologist, am most familiar with, is that we do a population survey. And a population survey is very much something that is research-focused and very intensive, but it turns out when we do that, we get a lot more information than you can get from routine data. We get information on all of the different parts, all of the inputs, outputs, outcomes, and impacts that we're interested in, as well as some more detailed sociodemographic data and data on a variety of harms. So just to summarize how we're collecting our data, We're collecting data on inputs, outputs, outcomes, and impacts, and we're collecting them all using a variety of different tools and collecting data from a variety of different individuals. This, I think, provides us with some significant benefits in that we're getting information from the people who can provide it to us the best. We're getting information from the client on what he or she thought of the self-testing process, for example, but we're also getting information from the CBD and from the facility. The problems with this are unfortunately quite, I wouldn't say that they're problems, it just makes it a lot of work. So it's a lot of work to make sure that you can track a single individual across all of these data elements. And even if you are able to track them, even if your data are perfectly clean, which those of us who work with data know doesn't usually happen, you still have to analyze it all. You still have to bring it all together, and that requires a lot of person time. And it's also a heavy burden on clients, community-based distributors, and facility staff, all of whom we have heard are overburdened with additional work or just going about their daily lives. So on the one hand, this is very much a research-intensive way of collecting data. I think that the lessons and some of the tools can be adapted for more routine data collection, but at the same time, I think that part of this is to open us up to thinking about, well, if we really want to know some of these very detailed questions about linkage, for example, we really have to put in a lot of effort into measuring these things and to start thinking about the costs and benefits of that. So that's all I have to say. All of these tools are available on the hivstar.lshtm.ac.uk website. Along with a lot of other information about the project that might be useful for you if you're interested in how STAR's been working with self-testing or looking at resources for developing your own research or your own M&E. And my information is available in the program if you want to email me directly. Thank you.